Every bone density test your doctor has run on you is measuring the wrong thing. And the calcium supplement sitting in your medicine cabinet right now, the one your doctor told you to take every single day, may actually be making your bones more fragile, not less. I know that sounds backward. I know it contradicts everything you've been told for 30 years. But I have spent 2 decades studying bone metabolism in aging adults, and what the research now shows is both alarming and, if you stay with me today, genuinely reversible. My name is Dr. Paul. I spent 22 years in clinical medicine, the last 14 of those working directly with seniors dealing with fractures, spinal compression, and the kind of bone loss that changes a person's life completely and permanently. I've sat across from patients in their 60s and 70s who did everything right, took their calcium, drank their milk, followed every piece of advice their doctors gave them, and still shattered a hip on a Tuesday afternoon stepping off a curb. I got tired of that conversation. So I started asking why. In a few minutes, I am going to tell you exactly what you should be eating instead of relying on calcium. It is something most people have in their kitchen right now and have never once connected to bone strength. But I am not going to tell you what it is just yet. Because if I tell you the name before you understand the mechanism, you will treat it like another supplement, take a little bit of it, and feel like you've done your part. That is not what I want for you. I want you to understand the biology so deeply that you never think about your bones the same way again. So stay with me. Let me tell you about Dorothy. Dorothy was 67 when I first reviewed her case. She was sharp, active, retired schoolteacher who walked 2 miles every morning and had never smoked a day in her life. She had been taking 1,200 milligrams of calcium carbonate every day for 11 years, exactly what her primary care doctor had recommended after her first DEXA scan showed mild bone thinning in her lumbar spine. She also took a standard vitamin D3 supplement. She did resistance exercises twice a week after reading that weight-bearing movement was important for bones. On paper, Dorothy was the model patient. She was doing everything the guidelines said to do. Her second DEXA scan, 4 years into the protocol, showed slight improvement. Her T-score moved just enough that her doctor called it a success and told her to keep doing what she was doing. Dorothy kept doing what she was doing. Then she turned 64 and had a third scan. Her bone density had dropped again, back below where it started. Her doctor added a bisphosphonate medication. Dorothy took it faithfully. Side effects were rough, jaw aching, some acid reflux, but she pushed through because she trusted the process. At 67, Dorothy bent over to pick up her granddaughter's toy off the living room floor. She felt something give in her lower back. She described it later as a sound more than a pain. A dull, dense crack that she felt in her chest even though the injury was in her spine. A compression fracture of her T12 vertebra. Not from a fall, not from an accident, from bending forward in her own living room. She lost nearly an inch of height in the months that followed as that vertebra slowly collapsed inward. The pain was constant for over a year. She stopped her morning walks. She stopped lifting her grandchildren. She stopped bending, reaching, trusting her own body. What Dorothy's doctors never told her, and I genuinely believe they did not know, was that every milligram of calcium she had been swallowing faithfully for 11 years was essentially wandering loose in her body without a destination. Without the specific biological signal that tells calcium to go to bone tissue rather than arterial walls, a significant portion of that calcium had been doing something far more dangerous than nothing. Studies now show that high-dose isolated calcium supplementation, without the cofactors that direct it, correlates with a measurable increase in arterial calcification, a stiffening of the vessels that supply the heart and brain. Dorothy was told her bones needed calcium. She was never told that calcium needs a guide. That guide has a name, and I'll give it to you in a moment. First, I need you to understand why the calcium story has been so incomplete for so long. Think about bone the way you'd think about a building. The frame, the structural skeleton holding everything together, is not made of calcium alone. It is made of a protein mesh called collagen. Type 1 collagen, to be precise. Calcium crystals, in the form of hydroxyapatite, are embedded within that collagen mesh. The collagen gives bone its flexibility, its ability to absorb impact without shattering. The calcium gives it its hardness. Take away the collagen and you don't have bone. You have chalk. Brittle, chalky material that snaps under compression instead of bending with it. Here is the part that almost no one in conventional medicine talks about clearly. After 60, your collagen synthesis rate drops significantly. The scaffolding weakens before the calcium even has a chance to embed. So when you flood the system with calcium supplements, you are pouring mineral into a deteriorating mesh. The calcium has nowhere to properly anchor. It circulates. And calcium that circulates, that is not claimed by bone tissue, gets deposited in places it was never meant to go. Blood vessels, kidney tissue, soft tissue throughout the body. Now add to this picture something called vitamin K2. Not vitamin K1, which most people know as the clotting vitamin found in leafy greens. K2 is a separate compound, a fat-soluble vitamin with a completely different role. K2 activates two proteins in your body that are critical for bone health and vascular health simultaneously. The first is osteocalcin, a protein produced by bone-building cells called osteoblasts. Osteocalcin, when activated by K2, grabs calcium from the bloodstream and locks it into bone tissue. Without K2 activation, osteocalcin sits there inert and calcium drifts past it. The second protein K2 activates is called matrix GLA protein, or MGP. MGP's job is to prevent calcium from depositing in arterial walls. It is essentially the body's vascular protection system against calcification. MGP is also K2 dependent. When K2 is low, MGP stays inactive, arterial calcification proceeds unchecked, and the calcium you are swallowing ends up in the exact wrong place. A clinical study published in the journal Osteoporosis International tracked postmenopausal women over 3 years. The group that received K2 in the form of MK7 alongside their calcium and vitamin D showed significantly less vertebral bone loss compared to women who received calcium and D alone. Not slightly less, significantly less. The Rotterdam study, a long-term population study in the Netherlands, found that the highest dietary intake of K2 was associated with a 52% reduction in aortic calcification and a 57% reduction in cardiovascular mortality. Two things happening simultaneously: stronger bones and cleaner arteries, because of one nutrient most doctors never test for and most patients never hear about. I want to pause here and ask you something. If you are over 60 and you have been taking calcium supplements, comment below right now. Just write your age and the word calcium in the comments. I want to see how many people watching this are in exactly the same position Dorothy was. And if you have ever been told your bone density is low or declining, add the word low after your age. Just your age and what applies to you. I read every single comment. Let me tell you about Raymond. Raymond was 71 when his daughter found this kind of research and brought it to him. He had been managing osteopenia in his hip for 6 years, taking calcium supplements, vitamin D, and a bisphosphonate his rheumatologist had prescribed. His most recent DEXA scan had shown that despite the medication, his bone density in his femoral neck, the part of the hip most vulnerable to fracture, had not improved. It had held roughly steady, which his doctor called acceptable. Raymond did not find it acceptable. He had watched his older brother fracture a hip at 74 and never fully recover. Raymond was not interested in acceptable. Raymond changed 3 things. He stopped the high-dose isolated calcium carbonate and replaced it with a food-based approach focused on calcium from sources that naturally come paired with the cofactors the body uses to place calcium correctly. He added a specific dietary source of K2 that I am going to describe in detail in a moment. And he added a targeted collagen protocol. Not a collagen face cream, not a beauty product, but a specific form of bioactive collagen peptide that clinical research has shown stimulates osteoblast activity, meaning it signals the bone-building cells to accelerate production of new collagen matrix. 18 months later, Raymond's DEXA scan showed a measurable improvement in bone density at the femoral neck. His rheumatologist, who had been skeptical of the changes Raymond described, asked him to bring whatever information he had read to the next appointment. That is the conversation I want every person watching this to be able to have. Now let me tell you about Frances. Frances was 65, a former nurse who had heard about K2 and immediately went to her local pharmacy and bought the most accessible thing she could find, a standard vitamin K2 supplement in MK4 form, which is the synthetic version most commonly sold. She took it for 8 months alongside her existing calcium regimen. She felt no difference. Her follow-up bone scan was essentially unchanged. Frances came to the conclusion that the K2 research was overstated. What Frances didn't know is that MK4 and MK7 are not the same thing clinically. MK4 has a very short half-life in the bloodstream, roughly 1 to 2 hours. To achieve therapeutic concentrations from MK4 alone, you would need doses that are not practical from standard supplements. MK7, on the other hand, is the long-chain form found predominantly in fermented foods, and particularly in one specific fermented food that has the highest natural concentration of K2 found anywhere in the human diet. MK7 has a half-life of approximately 72 hours in the body, 3 full days. It accumulates. It reaches the tissues. It activates osteocalcin and MGP in a way that MK4 at standard supplement doses simply does not sustain. Frances switched to the dietary source of MK7 I am about to describe. She also made one additional change. She started eating foods that support collagen synthesis, specifically those rich in glycine, proline, and the trace mineral silicon, which are the raw structural materials the body uses to manufacture new type 1 collagen. Her third bone density scan, 14 months after the change, showed a measurable difference. She called my office and told me she wished someone had explained the difference between MK4 and MK7 before she spent 8 months on the wrong form. Now I want to be honest with you about why this information is not what comes up in your average doctor's appointment. Medical education in bone health has been shaped largely by the research that was funded during the decades when bisphosphonates and calcium supplements were the primary commercial tools being developed. That is not a conspiracy, it is economics. When a drug costs pennies and a lifestyle intervention generates no revenue, the clinical trials, the medical school curriculum, and the guidelines committees all skew toward the profitable option. Your doctor is not ill-intentioned. Most doctors I know are deeply good people doing their best with the framework they were given. But the framework has a blind spot. Vitamin K2 is not covered meaningfully in most medical school training. Collagen scaffolding in bone is mentioned, but its implications for supplementation are almost never discussed. The nuance between calcium forms, cofactors, and tissue destination is treated as specialty knowledge, not frontline primary care knowledge. That gap costs people like Dorothy and Frances and Raymond years of declining bone density that could have been addressed earlier. If you have found what I'm sharing useful today, if this is the kind of conversation nobody has had with you about your bones, please take 5 seconds right now and hit the subscribe button and give this video a thumbs up. It costs you nothing, and it tells the algorithm to put this information in front of more people who need it. And if you have a mother, a father, a sister, a spouse over 60 who takes calcium supplements every day without knowing what you now know, share this with them directly today. Because a compression fracture in a spine changes a person's life, and most of them are preventable. Here is what you actually need to be eating after 60 to support real bone strength. Not just bone density numbers, but the structural integrity that prevents fractures when it matters. The single most important dietary addition for bone health after 60 is natto. Natto is a traditional Japanese fermented soybean food. I understand that for most people in the Western world, natto is unfamiliar, and I will be completely honest. Its texture and smell are acquired tastes. but a single 2-ounce serving of natto contains more MK7 than any other food on the planet by a significant margin. Studies measuring serum K2 levels show that regular natto consumption produces measurably higher MK7 tissue concentrations than any supplement dose achieves comparably. Japanese women who consume natto as a staple have significantly lower rates of hip fracture compared to American women of similar age, despite having comparable or lower calcium intakes. That is not coincidence. If you cannot tolerate natto directly, fermented hard cheeses, particularly Gouda and Brie aged traditionally, contain the next highest concentrations of MK7 from dairy fermentation. Fermented vegetables. Sauerkraut, made traditionally, not pasteurized, also contribute, though in smaller amounts. Beyond K2, the next non-negotiable piece is bone broth made from actual bones simmered for a minimum of 12 hours. Bone broth prepared correctly is the most bioavailable source of the collagen precursors, glycine, proline, hydroxyproline, that your body uses to rebuild bone matrix. This is not about the collagen staying intact through digestion. It is about the breakdown products of collagen, specific peptides, that have been shown in clinical trials to directly upregulate osteoblast activity and downregulate osteoclast activity. Osteoblasts build bone. Osteoclasts break it down. After 60, the ratio shifts increasingly toward breakdown. Collagen peptides, specifically those from bone-based sources, push the ratio back toward building. Look for bone broth made from knuckle bones or marrow bones, simmered low and slow, that gels when refrigerated. That gelation is your signal that the collagen content is meaningful. The third critical dietary component is magnesium, specifically from food rather than supplements where possible. Roughly 60% of adults over 60 are functionally magnesium deficient by cellular measurement, not serum measurement, which is notoriously inaccurate for magnesium status. Magnesium is required for the enzyme that converts vitamin D into its active form. Without it, the vitamin D you take does very little for calcium absorption. Pumpkin seeds, dark leafy greens, particularly Swiss chard and spinach, hemp seeds, and dark chocolate above 85% cacao are excellent dietary sources of magnesium that also bring other bone-supportive compounds with them. The fourth element, and this one surprises most people, is dietary silicon. Silicon is required for collagen cross-linking, the process that makes collagen strands bind together into a strong, organized mesh rather than loose, tangled fibers that lack structural integrity. Bone with poor collagen cross-linking fractures far more readily than bone with proper cross-linked collagen, regardless of mineral density. The best dietary sources of bioavailable silicon are horsetail herb tea, oats, cucumbers with the skin on, and green beans. These are not glamorous foods. But the research on silicon and bone matrix quality is compelling and deeply underreported. Now let me address the questions I know are forming in your mind. If calcium supplements are problematic, does that mean you should stop taking them entirely? Not necessarily, and not without speaking to your doctor first if you are on a prescribed dose. What the research suggests is that high-dose isolated calcium carbonate taken without K2 and magnesium is the problematic pattern. Calcium citrate is better absorbed and causes fewer issues than calcium carbonate. Lower doses from food sources, dairy, leafy greens, canned sardines with the bones eaten, tofu made with calcium sulfate, deliver calcium alongside naturally occurring cofactors that improve its handling. If you are going to supplement, the evidence points toward lower doses of calcium citrate taken with K2 as MK7, vitamin D3, and magnesium glycinate as the combination most likely to direct calcium into bone rather than elsewhere. What if you are already on a bisphosphonate medication? Do not stop taking it without discussing with your doctor. Bisphosphonates work by suppressing osteoclast activity. They slow breakdown. The dietary protocol I've described works on a different axis. It supports the building side of the equation. They are not inherently incompatible. What I would encourage you to do is bring this information to your prescribing physician. Ask about K2 levels specifically, and ask whether a DEXA scan with trabecular bone score, not just standard bone density, gives a more complete picture of your fracture risk. Is Natto safe for everyone? People on warfarin or other vitamin K antagonist blood thinners need to be aware that high K2 intake can interact with these medications. This is a real consideration and requires a conversation with your prescribing doctor before making significant dietary changes involving fermented foods. If you are on a blood thinner, do not simply start eating natto every day without that conversation. One more question I hear often. Does any of this actually reverse bone loss, or does it only slow it down? The answer depends heavily on how early you start and on the overall metabolic environment. Raymond's case involved measurable improvement. Several clinical trials on K2 and collagen peptides have shown actual density gains, not just stabilization, particularly in the first 1 to 2 years of consistent use in postmenopausal adults. The further into bone loss progression you are, the harder reversal becomes. But stabilization and partial recovery are realistic in most adults under 75 with consistent dietary intervention. I want to ask you one final question in the comments before I close today. Drop one of 3 things below. Write building if you feel like you have a plan now and you're going to start making these changes. Write questions if there's something I covered that you need me to go deeper on in a future video. Or write doctor if you're planning to bring this information to your physician and have a conversation. Building, questions, or doctor. I read all of them, and your answers directly shape what I cover next. Let me bring Dorothy's story back to where it belongs, at the close of this conversation, rather than just the opening of it. Dorothy came across information about K2 and collagen 18 months after her compression fracture. She was still in pain, still rebuilding her confidence in her own body. She changed her diet deliberately and consistently. Natto 3 times a week, even though she found the taste difficult at first. Bone broth made weekly from her own kitchen. Magnesium-rich foods daily. Her next DEXA scan, taken 20 months after the compression fracture, showed something her doctor called unexpected. Modest but measurable improvement in her lumbar spine density. Not dramatic, not a complete reversal, but movement in the right direction when movement in the right direction was not supposed to be possible without pharmaceutical intervention. Her doctor asked her what she had changed. She told him everything. He sat quietly for a moment and then said he needed to look more carefully at K2 research. That is the conversation I want every one of you to be able to have. Not a confrontation with your doctor, not a rejection of medical care. A more complete, more informed conversation where you bring real evidence to the table and advocate for a broader approach to your own bone health. You have earned that conversation. You have earned the right to understand your own biology. And you have earned the right to know that calcium alone was never the whole answer. My name is Dr. James Miller. This is Senior Health Daily. And what I do here, what I will keep doing, is give you the information that closes the gap between what medicine officially recommends and what the research actually supports. Because that gap, in the case of bone health after 60, is the difference between Dorothy bending over safely in her living room and Dorothy spending 14 months recovering from a fracture that did not have to happen. Before you go, the next video I am releasing addresses something that the majority of women over 60 and a surprising number of men are doing every single night that is actively accelerating bone breakdown while they sleep. It involves something you probably have in your bedroom right now. Click that video next, or it will be waiting for you the next time you open this channel. And if you have not subscribed yet, do it before you close this page. I release new research every week, and the algorithm does not always show it to people who haven't subscribed. Hit that bell so you don't miss what's coming. Thank you for your time today. Now go make some bone broth.